Medicine is a service. It is also a skill that is very similar to the practice of law. It involves three steps: collecting information, matching the information with a code from a directory, then deciding based on that code what is the remedy for that particular situation. The lawyers, defense attorneys, prosecutors collect information by asking questions and looking at evidence. In medicine, a clinician, this time, also asks questions and looks at the evidence, which is in medicine, test results, other clinicians' reports. The lawyers match the real life situation to a certain type of law breaking. Of course, the defense attorney tries to demonstrate that there was no breaking of the law, or if it was a variety much less severe than what the prosecutor is trying to demonstrate. Clinicians match the information they collect with a certain type of pathology. Then the process diverges a bit. In the practice of law, a third person, a judge, decides type of infraction, do the facts match, and what is the appropriate remedy. In medicine, the clinician himself has to decide what code is the closest to the facts and what the remedy or treatment should be. In practice of law, the remedy is prison time or some other form of punishment, and its implementation is passed on to another sector altogether, the Department of Corrections. In medicine, the clinician, again, is the one to apply the remedy or the treatment. So a single person manages the whole process from collection of information to applying the remedy, that means treatment. The law practitioners used forever the same system of getting paid. Some are going to be paid a salary, like the prosecutor, and others, the defense attorney, will be paid by the client for the time spent thinking about the case. When it comes to clinicians, the pay also comes as a salary or as an insurance payment. Very rarely, the payment may come from the patient directly. In order for the insurance to know what to pay, the medical service must be quantified in the same way as the diagnosis is quantified. The catalog of all possible diagnoses in psychiatry is called DSM-5, that means Diagnostic and Statistical Manual 5th edition. The catalog of medical services is called CPT, or Current Procedural Terminology. The name also includes the current year since it is revised annually. So the catalog with medical services is called CPT 2026. Quantification of such an ethereal piece of thinking is a challenge. The law practitioners choose an imperfect system by selling units of time of thinking. The insurances are not happy to apply the same system of time spent thinking about a case, but they could not scrap it altogether either. So the time spent thinking still exists, but in parallel with a new system which the insurance is trying hard to promote over the time definitions, in the sense that they will become suspicious of too many times the code being defined by time. And as a clinician, you will complicate your life, raising the risk of audits if you use the time definitions too often. The insurance considers the new system, which we are going to look into in much more detail, much less prone to abuse by clinicians who are going to try to maximize their income while the insurance is trying to minimize it. So the insurance industry, the payer of services, turned to American Medical Association and asked them to reinvent the catalog of possible medical procedures and come up with a code of around 5 numbers to correspond to a well-defined set of characteristics, less prone to manipulation than plainly the clinician time. We are going to focus today only on the process of translating the clinician thinking process into distinct entities for the purpose of putting a price tag on them through this new system of medical decision making. AMA came up with this system that is, in their opinion, much more complex than simple translation into time spent on a task. The reasoning was that since medical thinking is such a complex process with many dimensions, a simple appraisal like time spent on a task is a very imperfect system, and they need a new, more complex approach. So they developed the style of billing called medical decision making. In this system, time becomes irrelevant. What is being paid is judged by three factors: how severe the problem is, how extensive the data needed to solve the problem, and how much risk is involved in that particular treatment effort. The system is definitely logical since it no longer rewards the time spent on a task, but the difficulty of the task. A smart clinician, that means someone who thinks fast, has a large knowledge base stored in his memory, and can come up with solutions fast, will be rewarded better per unit of time than someone who thinks slow, has a reduced knowledge base, and a reduced capacity to assemble that knowledge into solutions. Of course, there is also a system of rewarding results, no matter the time or the complexity of the medical thinking. But this is not used in the practice of law and not used in the practice of medicine, since both are complex processes dependent on many factors, some of them to a great extent or entirely out of the control of the practitioner in medicine or law. In the practice of law, this source of uncertainty in outcome is the judge. In medicine is the complexity of the human body, but also the ability of the patient to comply with the treatment measures and the environment in which the patient resides. So neither the practice of law or medicine does not guarantee results, and it is not rewarded according to results. All that is guaranteed is that the advice will be given according to the prevalent standards of practice. I'm going to present the medical decision model of quantifying medical services, and you must concentrate on what I'm saying since it is more complicated than listening to a news podcast or music. Have some patience until the end because I will give you the shortcut you can use to justify a certain build code. The CPT codes are of two kinds, those referring to medication management and those referring to psychotherapy. The codes that refer to psychotherapy remain entirely under the old system, time spent on the task. When it comes to medication, the system based on medical decision making is the main yardstick. To make it easier to understand, medical decision making system can be of four levels. And the level is judged, as I said before, by three parameters. Two of them more concrete, easier to quantify, and the last one a little more difficult to capture in a rigid category, since it is on a continuum like the shades of gray between light and dark. The first two elements are the number and severity of problems, which are almost identical with symptoms, the amount of data that needs to be collected to resolve a problem, and the last one is the risk, which is a continuous variable like the temperature that goes from cold to hot and can take any possible values in between. So medical decision making can be of four kinds: straightforward, low, medium, and high complexity. This is defined by using three parameters: problem, data, and risk. Each of these parameters has four levels of intensity: minimal, low, moderate, and high. In order for the medical decision making to be called straightforward, low, medium, or high, 2 out of 3 determining parameters must be at the claimed level or higher. Now we have to define what means minimal, low, medium, and high for each of the 3 parameters involved in deciding the level of medical decision making. We will start with the parameter problem. It has 2 dimensions, acute versus chronic, and intensity. What is chronic or acute? Acute means a new sudden short-term problem, or it can be acute on chronic, which means a chronic condition that has suddenly worsened. Chronic means a long-standing condition that persists over time. The intensity can be minimal, inconsequential, and needs no treatment, for example, upset because of a minor argument with spouse. Low, for example, low energy in someone who still can work full time. Moderate, for example, low energy, which already is causing occasional absenteeism from work. And high, when the low energy, as I gave as example, is to the point that the patient barely gets out of bed for ADLs, let alone going to work. Any symptom can have any of these intensities. Now, levels of data that is needed to make the diagnosis can be minimal or none, moderate, low, moderate, or high. Minimal, no data reviewed, no external records, no third-party reports, no test orders. Low means one out of the following: review of tests, labs or imaging, ordering tests, reviewing of external notes, use of an independent historian. Moderate is 3 out of the same list. That means review of test, ordering test, review of external notes, independent historian. High means 2 out of 3 categories. And category 1 is review of tests, ordering test, review of external notes, independent historian, the same as above. Category 2 is interpretation of a test, and category 3 is discussion with an external physician or a qualified healthcare professional. Risk has the following levels: minimal, almost inconsequential if things go wrong; low, when just over-the-counter medications or no medications are used; moderate, when prescription medications need to be used; high, when controlled medications are used, or medications that need active monitoring, like lithium, neuroleptics, or other medications, or the presence of suicidal ideation, active or passive. Let's see now, how do we choose the CPT code? When the medical decision-making is low, that means the problem parameter consists of one mild transitory issue, like a reaction to an unpleasant event that is non-recurring and brief. When the data collection needed is very low or inexistent, when the risk is minimal or none, we use the code 99213. In my opinion, in psychiatry, 99213 should not be used. We never get a patient in for an appointment and we collect no or minimal information. Since this would create a professional liability risk, therefore, it should not even be considered. When medical decision-making is moderate, that means the target problem is one chronic condition with acute exacerbation, or 2 stable chronic conditions, or one new acute problem needing workup. And the data collection needed is moderate, for example, multiple tests, external notes, interpretation of tests, and the risk is moderate, for example, prescription medication used or medication changes. Then we use the code 99214. When medical decision-making is high, that means the problem is one chronic illness with severe exacerbation or a threat to life, suicidal, homicidal ideation, and data collection is high, for example, multiple sources, discussion with another clinician, and the risk is high, drug toxicity, monitoring for severe side effects, safety concerns. When lithium Depacon neuroleptics are used, then we use 99215. In the past, the requirements were so Byzantine that they were scrapped. There were requirements that had to be met for a problem-focused patient's history, for an expanded and comprehensive history taking, and the same for objective examination, which in psychiatry is practically the mental status examination. It was far too cumbersome, so the only thing we need to pay attention Uh, Now is the new definition as above. A code that I'm not going to discuss here since it is a very lengthy discussion is the Initial Evaluation Code 90792. But just briefly, in order to be called an initial evaluation for billing purposes, it is safe to assume, but it is not actually specified in the description of the CPT code, that you need to have a chief complaint, history of present illness, mental status examination, assessment, diagnosis, plan, family history, social history, drug history, and so on. There is no time requirement specified for the initial evaluation 90792. Now, very important to understand that the progress note has three main functions. One, to help you deliver adequate and coherent treatment. Two, to close any loophole that any hostile observer might use to prove you did a bad job. This can be the patient, patient's family, or some representative of the patient. Three, to close any loophole for the insurance to claim that you did not provide the service you claim you did through the billing code. This, in addition to keeping in mind that you have to minimize the time spent on filling paperwork, since that activity has no value for the patient. Now, the shortcut I talked about earlier. And I'm going to mention only the codes 99214 and 99215 since they are the only ones worth considering. Whether in isolation or in addition to psychotherapy, 30 minutes, 90833, 45 minutes, 90836, and 60 minutes, 90838. I'm not going to focus on therapy codes since the only criteria for billing purposes is the time spent on the task. That means you must add clearly to the note psychotherapy 30, 45, or 60 minutes, and the beginning and the end time as well. If you do not put the beginning and the end time, you leave a loophole open for the insurance to refuse to pay, no matter how absurd that pretext may be. So my advice for 99214 is to start the note with the statement, medical decision-making, moderate, based on, number one, complexity of problems. List one chronic problem with exacerbation or two stable chronic problems or new acute problem. Then, number two, data reviewed, multiple tests or external notes of interpretations of tests. Then you mention, number three, risk, moderate, prescription medication reviewed. Practically all patients are in this category since all of them are on prescription medications. For 99215, the note starts with medical decision-making high based on, complexity of problems, one chronic illness with severe exacerbation or one acute illness posing threat to life or function, either to self or others. And of course, name specifically what is that condition or symptom. And data reviewed, multiple sources, discussion with another clinician, can be any clinician, doctor, nurse practitioner, nurse, certified social worker, case manager, and so on. Interpretations of tests like Montreal Cognitive Assessment or Hamilton Depression Scale, and so on. Risk must be high. For example, use of controlled medications or medications that need monitoring like lithium, Depakote, Tegretol, neuroleptics, and others. Or suicidal ideation, present, passive, or active. And another very valuable tip, medical decision-making, to be defined as moderate or high, needs only 2 out of 3 parameters to be at or above the claimed medical decision-making level. So practically, to save time, you really must mention only the 2 parameters that meet or exceed the medical decision-making level. The way the new CPT code definition spelled out, data reviewed might be difficult to achieve, even a moderate level, because most of the time you do not review or interpret any tests, you do not have access to third party for information. But the risk is for almost everybody moderate, since almost everybody is taking prescription medication. For 99215, if you cannot justify high levels for at least two parameters, then you do have the choice to use the time definition by stating that the meeting lasted 40 minutes and specify the starting and ending time, and that more than 50% of the time was spent discussing medical matters. So 99214 can be as simple as MDM, moderate, period. Problems, moderate, colon, one chronic, comma, sadness with exacerbation. Risk, colon, moderate, comma, prescription medication reviewed. That's it. And then in 99215, it can be as simple as 40 minutes meeting from 2 to 2:40 p.m., more than 50% of the time discussing medical matters. That is it, one or two sentences. But of course, the note must address the other two purposes. That means reminding yourself where were you with the treatment and close any loophole for any claim of not performing up to the standard of care. So this is just a skeleton of the note you need for the billing purposes. On that skeleton, you add whatever you feel is needed to remember next time what was done in order to make the treatment coherent over time, and what is needed to prevent anybody from claiming the service was not up to the standards of practice. That means make sure you do the classic SOAP note as well, with evidence of having asked all the right questions, document the answers of the patient, and document that you communicated to the patient all the things the patient must know about the treatment, like the purpose of each medication, possible side effects, expected benefits, how to titrate the medication or taper it off, and what to do in case certain problems appear. These last two purposes of the progress note will be addressed elsewhere, since the focus today was on billing codes.